Leslie, are you going to continue to host or are you going to transfer it?
I'm going to ask everyone to make sure that their device that they're accessing the hearing from is muted. Looks like there's a couple people who are not muted.
Ryan, I've made you host now. You're still muted, Ryan.
I have to do the admitting.
I'm sorry?
As the host, I have to do the admitting, right?
I'm not sure. We'll see how it works.
There's someone in the waiting room. Can you do it or do you want me to?
Oh, yes. Yeah, I'm not seeing it now.
Okay. All right. Got it. Thank you.
I'm going to ask Attorney Monahan, it looks like you're not muted. And then Laura Sasser-Cuff is not muted. I'm going to ask you both if you wouldn't mind muting yourselves.
Michaela, this is Donna Hanley. I am with Laura Sasser-Cuff and she's not connected by audio.
Okay. Okay. Thank you. That helps. Thank you.
You're welcome.
Attorney Monahan, are you able to mute your device? All right, good morning. It looks like everybody's been muted. If you can hear me, just kind of put a thumbs up. I just want to make sure everybody can hear me. Thumbs up, I'm seeing them. Thank you. All right, so this public hearing today before the Health Systems Planning Unit identified by docket number 1932311 is being held on August 12, 2020 to establish an outpatient surgical center in Plainfield, Connecticut by Hartford Healthcare. On March 14th of 2020, Governor Ned Lamont issued Executive Order 7B, which in relevant part suspended in-person open meeting requirements. To ensure the continuity of operations while maintaining the necessary social distance to avoid the spread of COVID-19, the Office of Health Strategy is holding this hearing remotely. We ask that all members of the public and all participants mute the devices that they are using to access the hearing and silence any additional devices that are around them. This public hearing is being held pursuant to Connecticut General Statutes, Section 19A, 639A, and will be conducted as a contested case in accordance with the provisions of Chapter 54 of the Connecticut General Statutes. My name is Michaela Mitchell. Victoria Veltri, the Executive Director of the Office of Health Strategy, has designated me to serve as the hearing officer in this matter. My colleagues, Brian Carney and Jessica Rival, are also here to assist me in gathering facts related to this application. The Certificate of Need process is regulatory, and as such, the highest level of respect will be accorded to the parties, members of the public, and to our staff. Our priority is the integrity and transparency of the process, and we just ask that decorum be maintained by all those present during these proceedings today. The hearing is being recorded and will be transcribed by BCT Reporting LLC. All documents related to this hearing that have been or will be submitted to the Office of Health Strategy are available for review through our CON portal, which is accessible on the Office of Health Strategy's CON webpage. In making its decision, the Health Systems Planning Unit will consider and make written findings concerning the principles and guidelines set forth in Section 19A 639-639 of the Connecticut General Statutes. Hartford Healthcare is designated a party in this proceeding. Day Kimball Hospital has been designated as an intervener with full rights of cross-examination in this proceeding. At this time, I'm going to ask staff to read into the record those documents already appearing in HSP's table of record in this case. And I'm going to note that all documents have been identified in the table of record for reference purposes. Mr. Carney, thanks.
Brian Carney of OHS. And at this time, I'd like to read into the table of the record, Exhibit A through AA.
Are there any additional exhibits that you're aware of that we need to enter into the record besides those?
None that I'm aware of, no.
Okay. I'm gonna turn my attention to Attorneys Monahan and Attorney Fusco, just to make sure that there's nothing new that we need to consider adding to the table of record.
Thank you, Attorney Mitchell. This is Jennifer Fusco, counsel for HHC Plainfield. There are no additions to the record. The revisions were made yesterday that I had emailed you about. Two things, though. I do know there are some letters of support in the record from elected officials, and I had mentioned, and I do see that Kevin Cunningham, the first selectman of Plainfield, is on to speak this morning. We did have several doctors who were interested in speaking, but they're very busy right now. Their schedules are packed, sort of dealing with the pent-up demand from the COVID shutdown, and patient care is obviously the most important thing. So I told them that if they wanted to put in a written statement, they could get that to you in the form of a letter in the next day or so. Is that okay?
That works, yeah, that's fine.
Thank you.
All right. Attorney Monahan?
Good morning, and thank you for hosting this and giving us the opportunity to participate as you have. There are no new documents that I'm aware of at this moment that would be entered into the record, and I'll leave it at that.
All right. I do thank you both. So I'm just going to ask really quickly, do either of you have any objections to what's already been included in the table of record?
I have no objections.
All right, that's Attorney Fusco, and then Attorney Monahan.
I have no objection at this moment, but I'd like to reserve the right, as is commonly done in the course of a hearing, in the event that information comes out through testimony where there might be an appropriate motion to strike a particular document. Not that I have that in mind, but I do want to reserve that ability. But right now I have no objection.
Okay, all right, I'm going to note that. Thank you both. All right, if you wouldn't mind just muting your devices just for a few more moments. So we are going to proceed today in the order established in the agenda. I do reserve the right to allow public officials and any members of the public to testify outside of the order of the agenda. And if there's anybody that comes to your awareness that needs to go out of order, just let me know. I'd like to advise the applicants that we may ask questions related to your application that you may feel that you've already addressed. And we do this for the purpose of ensuring that the public has knowledge about your proposal for purpose of clarification and to ensure that the record is complete. I just want to reassure you that we've read all of the information that you've submitted. We've looked at completeness responses and pre-filed testimony. So just kind of bear with us if you feel like you've already responded to a question that we are asking. As this hearing is being held virtually, we ask that all participants, to the extent possible, enable the use of video cameras when testifying or commenting during the proceedings. We ask that anyone who is not testifying or commenting mute their electronic devices, including any devices that are in the vicinity of you that maybe you're not using to access the hearing. So that would include telephones, televisions, and any other devices like cell phones, just in case you accidentally unmute yourself. My colleagues and I are going to monitor the participants during the hearing, and to the extent possible, we've discussed this previously, but if counsel wants to let me know that something's going on, I'm going to ask that you use the raise hand function. If that's not immediately recognized, you have the option to unmute your device yourself and just indicate that you have an objection or you want to make a statement, and then I'll intervene. All participants can mute their devices and disable their cameras when we go off the record or take a break. But just so that we make sure that we capture everything, we are not going to stop the recording. So you need to be very careful if you're conferring with your clients or talking, that you make sure that you mute your device so that your conversations are not captured during the recording. We're not going to stop the recording. I'm going to provide a warning to all the parties 1 minute prior to going back on the record anytime that we take a break. And I noted that Attorney Fusco asked about submitting written comments. I just want to make sure that I reiterate that public comment taken during the hearing is going to go in the order established by OHS. I'm going to call each individual by name when it's his or her turn to speak. If there's anybody that wants to submit written comment after the hearing has been adjourned, I will give you instructions about how to do that. At this time, I'm just going to ask the attorneys if they wouldn't mind unmuting their devices if they're still muted. And I'm going to ask all of the individuals who are going to testify on behalf of the parties to be identified by their attorneys.
Okay, I can start. We have, in terms of written testimony and presentation, we have David Whitehead, who's the Executive Vice President and Chief Strategy and Transformation Officer for Hartford Healthcare. We have Karen Goyette, who's the Senior Vice President for Strategy and System Integration for Hartford Healthcare. Also here in the room, we have Bill Bitterly from Constitution Surgery. We have Donna Sassy, who is I wrote it down, Donna, but she's the Director of Ambulatory Services for HHC. And we have Barbara Dirty, who you know is the Director of Strategic Planning. We also have other witnesses remotely. We didn't want to have everyone in the same room. So I don't know if anyone who's on the call on behalf of HHC and the applicant that might testify could unmute and identify themselves. I know Jerry Boisvert, Donna Hanley, Laura Sasser-Cuff. I can't see everyone on our screen.
Ken Rosenquist from Constitution.
Yep, Ken.
Donna Handling, Hartford Healthcare East Region President.
Plainfield.
Can you repeat your name again? Kevin Cunningham. I got you. Thank you.
Plainfield First Selectman.
Got you. Thank you. Sorry about that.
Is Jerry Boisvert on? Yeah. He might be muted.
I want to just confirm that one of the people is Stephen Courtney.
I think he's on. He may be muted. I thought I saw his name. Oh, he's there. I see him. He's right in the middle of our screen now with headphones on. Jerry Boisvert. He's muted, but he's an HHC witness as well.
They're going to be there naming them that they may have.
All right. So let me just go through the list. I've got David Whitehead, Karen Goyette, Bill, is it Bitterly?
Correct.
Okay. Donna
Sassy.
Sassy, got it. Barbara Dirty.
Yes.
Jerry Boisvert, Laura Sasser-Cuff, Donna Handley, Kevin Cunningham. Did I miss anybody?
I think so. Jen Hamilton.
Ken
No, I
Rosenquist.
think that's everyone.
Ken Rosenquist.
Oh, Ken
Ken Rosenquist.
Ken Rosenquist from Constitution's on as well.
Yes.
Got you. All right. And Attorney Monahan, for you?
Yes. First, as a point of clarification, just based on the number of names that were just read, is it my understanding that those are individuals on behalf of the applicant who are present, but with respect to the order for pre-filed testimony, we only have 2 witnesses intending to testify on behalf of the applicant, namely Mr. Whitehead and Ms. Guyette. Is that correct?
Yes, that's correct. And those additional individuals have been brought, as is typical in OHS proceedings, to answer questions in different substantive areas to help get questions by OHS and interveners answered properly. So they're all available to answer questions as needed.
I appreciate that. Okay. On our end, we have 1 witness, Mr. Paul Bodwin, who is the Chief Financial Officer and most recently interim Chief Executive Officer of Day Kimball Healthcare. And he submitted pre-file testimony and he will testify here today. We have Mary Heffernan here in the room with me, who has worked with us and consulted on the case, who has not filed pre-file testimony, but may be available to assist Mr. Bodwin or the hearing officer in answering any questions that may come up.
All right, perfect. So I'm going to ask everybody who's been identified by name, if you wouldn't mind raising your right hand, and I'll go ahead and swear you in. All right. So I'm going to ask, do you solemnly swear or affirm that the testimony that you're about to give will be the truth, the whole truth, and nothing but the truth to help you God? I'll start with you, Mr. Whitehead.
I do.
Okay, Ms. Goyette.
I do.
Mr. Bitterly.
I do.
Ms. Sassy.
Yes, I do.
Okay, Ms. Dirty.
I do.
Mr. Boisvert.
I think he's on mute.
I think he's on mute. Can you guys unmute him?
I'm going to come back to him. Ms. Sasser-Cuff.
I do.
Okay. Ms. Handley.
I do.
Mr. Cunningham.
I do.
And Mr. Rosenquist.
He's off now.
I do.
All right. Mr. Boisvert.
I do.
Thank you. And then Mr. Bodwin.
I do.
And Ms. Heffernan.
I do.
All right. So we're going to go back and have everybody mute themselves again. Thank you so much for doing.
Ms. Mitchell, you're muted.
Thank you. All right, so we're going to go ahead and get started. I appreciate you letting me know that. So when giving your testimony, just make sure that you state your full name, that you adopt your pre-file testimony if you've submitted pre-file testimony, and then also just for the purpose of the individual that's going to be transcribing the testimony, just make sure that when you initially give your testimony that you spell your full name for them. At this point, we are going to go ahead and get started with the technical portion. I'm going to ask the applicants to proceed with their presentation or their testimony. Go ahead, Ms. Fusco.
Okay, thank you. We're going to be starting with David Whitehead.
Good morning, Attorney Mitchell and members of the OHS staff. My name is David Whitehead, D-A-V-I-D, W-H-I-T-E-H-E-A-D. I am an Executive Vice President and Chief Strategy and Transformation Officer for Hartford Healthcare. I adopt my pre-file testimony. Thank you for this opportunity to speak about our plan to establish a freestanding non-hospital-based ambulatory surgery center in Plainfield as part of a joint venture with Constitution Surgery Alliance. This proposal will offer an affordable, high-quality, alternate care setting for outpatient surgery not currently available in the community. It will also add capacity to meet the needs of physicians and their patients as more procedures are steered towards ambulatory surgery centers. First and foremost, I want to extend my thanks on behalf of Hartford Healthcare to you, Attorney Mitchell, and to the OHS staff in these unprecedented times to continue to be able to move forward with this public hearing and other public hearings as part of the overall CON process. I think we're all learning to live in a virtual meeting world. And I think this is your first CON public hearing that's being done virtually. And just kudos to you and the team for being able to pull this together and get us all together so that we can work through this proceeding. At Hartford Healthcare, we have spent virtually all of our time for the last 6 months responding to the COVID-19 pandemic, adapting the ways in which we provide care to those we serve, and planning for a post-COVID world where the delivery of healthcare services will necessarily be very different than it was before. My remarks today, in addition to addressing the more traditional basis for a CON, will highlight the ways in which COVID-19 has shaped health system planning and made a joint venture like the proposed Plainfield ASC all the more important. In addition to serving as Chief Strategy and Transformation Officer for the Hartford Healthcare System, I also serve on the Governor's Healthcare Cabinet as a healthcare industry representative appointed by the Governor. This affords me additional insight into the healthcare policy objectives of our state, which I use to guide Hartford Healthcare's development efforts. This proposal presents an opportunity for Hartford Healthcare and the state of Connecticut to advance our common goals of decreasing healthcare costs and promoting higher quality, better access, and more value for healthcare consumers. As the healthcare landscape in Connecticut evolves, the conversation is quickly focused around these key issues. How do we contain the growing cost of healthcare while at the same time ensuring safety, quality, and equitable access for all Connecticut residents, including the vulnerable and underserved patient populations? In January, Governor Lamont signed Executive Order Number 5, which acknowledges the need to improve health outcomes for Connecticut residents while reducing the rate of growth of healthcare costs, and proposes doing so through the implementation of healthcare cost growth benchmarks. This benchmarking initiative was lauded by OHS's Executive Director, Vicki Veltri, as good for families, business, and the state. As I mentioned in my written remarks, the state's policy objectives are aligned with the vision of Hartford Healthcare, which is to be a high-value health system providing patients with access to affordable, high-quality, patient-centered care close to home. The proposed ASC fits with these objectives by allowing patients to choose a care setting that provides the highest quality care while reducing their out-of-pocket expenses. This is particularly true for the Medicare population, which comprises 35% of the payer mix for the Plainfield Ambulatory Surgery Center. The Plainfield Ambulatory Surgery Center will also bring freestanding, non-hospital-based outpatient surgical capacity to the community, which has become increasingly important as payers, including Medicare, are driving more procedures to the ambulatory surgery center setting. This proposal also presents an opportunity for Hartford Healthcare to enhance the services we're able to provide outside of the acute care hospital setting. This has become increasingly important in light of the COVID-19 pandemic and a strong physician and patient preference to receive the safe, high-quality care in alternate care settings like ambulatory surgery centers. Going forward, we intend to offer as many services as possible outside of our hospitals in order to preserve hospital resources and provide patients with care in the settings that they prefer when clinically appropriate. The proposal before you today, if approved, would pave the way for the first and only freestanding non-hospital-based ambulatory surgery center in northeastern Connecticut. As you will hear from my colleagues, the proposed Plainfield Ambulatory Surgery Center will enhance access, affordability, and quality of care, and ensure meaningful choice for consumers of outpatient surgical services. At a time when controlling costs and promoting equitable access to high-quality care are at the forefront of the conversation, approving a safe, accessible, and affordable option like the Plainfield Ambulatory Surgery Center is essential. For these reasons, I urge you to approve our CON request and allow Hartford Healthcare and Constitution to help the state achieve the policy objectives we all share on behalf of Connecticut residents. Thank you.
We'll now turn our presentation to Karen Goyette. Bear with us while we move the camera. There you go.
Thank you. Good morning, Attorney Mitchell and members of the OHS staff. My name is Karen Goyette, K-A-R-E-N-G-O-Y-E-T-T-E, and I am the Senior Vice President of Strategy and System Integration for Hartford Healthcare. I adopt my pre-filed testimony and HHC rebuttal testimony. Thank you for the opportunity to testify in support of our proposal to establish a joint venture surgery center in the Plainfield, along with our partner, Constitution Surgery Alliance. And I share in Mr. Whitehead's comments of our thanks of you finding innovative ways for you to engage the public in these discussions. HHC is proposing the establishment of a state-of-the-art 2 operating room freestanding surgery center. The focus of the center will be orthopedics, pain management, urology, and gastroenterology services. As you've heard from Mr. Whitehead, this will be the first of its kind, a freestanding non-hospital-based ASC in the region. The center would serve as a long overdue enhancement to this community and the residents of this community, some of which today drive over 20 miles to have like types of services. The proposed Plainfield Center is consistent with HHC's current vision of delivering value to patients through a robust ambulatory network that offers affordable, safe, high-quality care with an exemplary customer service, safe to the homes and close to the homes that we serve in our community. For reference, Hartford Healthcare currently operates over 400 locations across Connecticut. They include 9 ambulatory surgery centers, 5 gastroenterology centers, 28 imaging centers, 18 urgent care centers, as well as a number in over 100 medical offices. The point of me bringing this up today is the fact that the Hartford Healthcare is not afraid to disrupt themselves to provide innovative ways to bring care close to home. The model that we'll talk about today and the structure of this partnership is one we've developed with Constitution throughout the state of Connecticut. In the 9 centers that we currently operate, we have seen firsthand the impact that they have had on cost, access, and quality for both physicians and the patient experience. We will speak to many of those factors this morning. In lieu of time, I will focus my remarks this morning on some of the ways this proposal is aligned with both the state policy objectives that Dave referenced, although it also meets the key statutory requirements that OHS must consider while looking at CONs. The first, the Plainfield Center will improve access to care, specifically for the types and treatments and procedures where demand for care is anticipated to grow the most based on patient demographics. This is going to be demonstrated in a number of ways. The demand for outpatient services in the Plainfield area is expected to grow due to an aging population where those patients have the most healthcare needs. Specifically, Plainfield area is expected to see a growth in outpatient procedures identified ranging from 3 to 5% annually. This is in stark contrast, and that is annually over the next 5 to 10 years. This is in stark contrast to the most recent inpatient projections for the same service area, was anticipated to remain flat and even decline 3.5%. Another factor is demand will also grow as technology advances, more procedures migrate to the ambulatory surgery setting. HHC experience for orthopedics specifically, we estimate that over the next 5 years, approximately 50 to 60% of total joint cases will be performed in an outpatient basis. Again, this is in stark contrast to 5 years ago, with virtually no or very few total joint cases were handled in the outpatient setting. And while there are various methodologies and associated pluses and minuses as we look at tracking population growth in the state and nationally, whether you look at the census, state town profiles, independent studies, the one thing that is constant for this market is there will be a double-digit growth within the 65 to 84-year-old population. And this, again, is the population that represents the greatest group with the most significant healthcare needs. The second factor and criteria I'd like to touch upon is patient choice in a more affordable setting. Ambulatory surgery centers are generally reimbursed at lower rates than hospital outpatient departments for the same procedures. For example, and we detailed this in our application, for Medicare patients who comprise approximately 35% of our proposed Plainfield Center payer mix, the differential and is significant, with ASCs being reimbursed on average at 50% of what you would expect in a hospital outpatient department. These savings are passed on to patients in the form of lower out-of-pocket expenses such as copays and deductibles. And it's particularly important for patients with high deductible health plans, which create barriers for many families seeking that care. And as true, and I think this is extremely important to highlight, of any of Hartford Healthcare's ambulatory surgery center joint ventures, we ensure access for all patient populations. This includes Medicaid recipients, which is projected to be about 17% of the patients that would seek care here. And Plainfield Center will also adopt all of Hartford Healthcare's financial assistance policies. The third criteria, the center will enhance both physician and patient satisfaction in a market that's been historically very hard to recruit to for top physician and surgical talent. There are a number of reasons why physicians enjoy an ambulatory surgery alternative. Physicians appreciate the increased control of their environment, the professional autonomy over their work environment, including ease of scheduling and access to specialized staff and equipment. To have this option in a state-of-the-art facility in Plainfield will assist in drawing top surgical talent to the area. Similarly, patients are highly satisfied with personalized care given smaller settings. This includes shorter wait times, fewer unforeseen delays. Within our existing surgery centers, and patient satisfaction scores typically range from 90 to 100% in willingness to recommend to others. And additionally, and this is an unfortunate situation, and Mr. White had highlighted this, in an environment that will now operate in the foreseeable future with COVID, we have found it to be extremely important for many of our patient populations to offer a safe environment alternative in a non-acute care setting, especially in older adults and those with pre-existing conditions. Finally, we would anticipate a limited to no impact on any area providers for the Plainfield Ambulatory Surgery Center. The CHIME data that we provided in the CON submission shows a total demand for orthopedic, pain management, urology, and gastroenterology surgical services in the area at about 5,750 cases. That was in 2019. This does not include patients who already travel out of pocket and out of this service area, and so it's most likely understated. I can state that in 2019, 1,000 cases originated from the Plainfield service area and were seen at the Waterford Surgery Center, some 35 miles away. In that time frame, 60% of the cases occurred in that service area at an HHC hospital. Therefore, the projected volume that we have included in the CON of 2,350 cases to 2,500 over the first 3 years annually, we anticipate reflects a shift from HHC, hospital-based centers, and an increased demand for the services based on demographics and need that I spoke of earlier. Based on the foregoing, and as further supported by our written submissions, we believe that all criteria has been met for a CON. As such, we respectfully ask OHS to approve this proposal for a Plainfield Surgery Center, and it truly will benefit the residents of this community. Thank you for your time. I have with me today colleagues from both Hartford Healthcare and Constitution Surgery Alliance to answer any additional questions you may have.
Thank you. Attorney Fusco, anyone additional that you want to present for your draft?
That concludes our presentation. Thank you.
Thank you. I'm going to turn it over to you, Attorney Monahan, for your presentation. Attorney Monahan, are you still there? Looks like you're still muted.
Can you hear me now? Okay.
Gotcha. Yes, perfect. Thank you.
I am prepared to have Mr. Bodwin testify. My question is whether you would like that preceding any cross-examination.
Yeah, so the testimony will go first. We'll do testimony for both sides. And then after that, I think I'm gonna take a statement from the first selectman, and then we'll go into cross.
Absolutely.
Okay.
Mr. Bodwin?
So good morning. My name is Paul Bodwin. That's Beaudouin. I'm the Vice President of Finance here at Day Kimball Hospital. Thank you for giving me this opportunity this morning to testify. I do adopt my pre-filed test.
Looks like we lost us.
Yeah, it's Mr. Bodwin, you were muted again for some reason.
Sorry about that. Are we back?
That's okay. That's okay. I just want everybody to kind of bear with us. We're going to have these hiccups throughout, and it's totally fine. We'll make sure that we get all the information that we need. Don't worry about it.
Thank you.
You're welcome.
So Day Kimball for over 125 years has been an integral part of the healthcare delivery system. Are you able to hear me?
I can hear you.
There you go.
Okay.
You're echoing though now because you
Now
must be in the
it's
same
better.
room. Yeah.
I think it's because Pat and I are in the same room. You've got to lower.
No worries. It's fine now. It's fine now.
Okay.
You're fine. There you go.
Yeah, there's some echoing going on here in the room. Is that better? All right. Thank you.
There we go.
So as I was saying, Day Kimball Hospital for over 125 years has been an integral part of the region's healthcare delivery system. In many respects, Day Kimball is a safety net providing essential services to the residents of Northeast Connecticut, with roughly 70% of the hospital's revenue derived from servicing Medicare and Medicaid patients. So a couple examples of how we are really a safety net here in Northeast Connecticut. One being that we provide over 22,000 emergency department visits, with nearly 40% of those visits being provided to Medicaid patients. Another is that we are the only obstetrical service within a 30+ mile radius, with over 50% of the births at Day Kimball being mothers on Medicaid. Nearly 50% of the patients that we provide behavioral health services to are Medicaid patients. We are the primary provider for behavioral health services in this region. From an economic perspective, Day Kimball is extremely important to Northeast Connecticut. We are one of the largest, if not the largest, employers in the 13-town region of Northeast Connecticut, employing approximately 1,000 people, the vast majority of those being residents of Northeast Connecticut. This application is extremely important to Day Kimball. We have some very significant concerns regarding what the loss of outpatient surgery volume could mean to our ability to provide needed services to this community, and frankly, potentially to its ability to survive, which, as you can imagine, again, during the period that we're in now, the pandemic and the COVID crisis, that's critical. We believe that this CON application is frankly not about need, but about an initiative to capture outpatient surgical market share that has the potential to severely impact our community hospital. And we have been working very, very hard to find ways to survive. From an access perspective, we do not believe the applicant has demonstrated the need in the proposed service area for additional outpatient surgery suites, as typically demonstrated by indicators such as scheduling delays, lack of available block time, demand that exceeds capacity. While I cannot speak to the indicators in other facilities servicing the the proposed service area, I can tell you that Day Kimball has significant capacity to meet current and future demand for outpatient surgery and endoscopy procedures. In fact, we are currently using only 3 out of our 4 surgical suites at Day Kimball. We're running at about 62% capacity for the 3 suites that are in operation, and our endo suites are running at approximately 64% capacity. And those are all pre-COVID percentages. We're concerned that transfer of existing volume out of our surgical suites to the ASC in Plainfield, to the proposed ASC in Plainfield, will decrease the cost effectiveness of our existing surgical service line, given the overhead we're forced to cover. We have concerns clearly around the proposed service area and the overlap between the service area as proposed for the Plainfield ASC and the Day Kimball service area for outpatient surgery. Whether that's 40% or 50%, those numbers, that overlap is very significant. And we are concerned that the service area, as identified in the application, could very much reach further north towards Day Kimball than what was identified in the application. And again, Day Kimball, between Day Kimball and the proposed site of the ASC, we're talking about a 20-minute drive. By providing investment opportunities in the ASC and the associated financial incentives to surgeons who currently operate at Day Kimball, including orthopedic surgeons who provided letters of support as part of the CON application filing, we do believe there is a high likelihood that these physicians will refer their patients to this proposed ASC. This would in turn negatively impact Day Kimball, as outpatient surgery and endoscopy is one of the service lines that does generate a positive contribution margin. And what that does is allows us to continue providing the services that generate negative margins and for which our Medicaid and Medicare patients depend so heavily on Day Kimball to provide. A real-life example of the potential financial impact of the loss of surgery volume and endoscopy volume is what happened just a few months ago during the COVID-19 crisis. When you look at the 1 month of April, which is really a full month of impact of the drop in elective surgery and drop in endoscopy procedures, Day Kimball experienced a $1 million decrease in net revenue just from outpatient surgery and endoscopy procedures being canceled during the heart of the COVID crisis. On an annual basis, that would be the equivalent of a $12 million drop in revenue, with an annualized bottom line impact of approximately $8 million. I realize that represents, what represented nearly a 100% drop in cases, but even a 30 to 40% drop in outpatient surgery and endoscopy cases, migrating away from the hospital to the proposed ASC would result in a $2.5 to $3.5 million reduction in our operating results. While this impact may be relatively insignificant to large systems, for Day Kimball, this has major implications, especially given the already fragile financial situation we and many small community hospitals find ourselves in, which has been further negatively impacted by the COVID crisis. For all those reasons I noted above, I request that you deny this application, and I thank you for your time this morning.
Thank you so much for your statements. I'm just going to ask Attorney Monahan, do you have anybody else that you wish to have speak?
There is no one else,
Okay.
Ms. Mitchell.
All right, so I'm going to ask if the first selectman for the town of Plainfield is available. We're going to go a little bit out of order, but I just want to make sure that the first selectman is able to offer their comments. And then after that, we can go into cross unless somebody needs a break. Is the first selectman available?
Yes, I am.
Okay, all right.
Good morning, Attorney Mitchell and the members of the OHS staff. My name is Kevin Cunningham, KEVINCUNNINGHAM, and I am the first selectman for the town of Plainfield, Connecticut. First of all, I want to thank you for the opportunity to speak about the benefits for the freestanding non-hospital-based ambulatory surgery center in Plainfield and what we'll have for our community. And I know that this proposal will offer an affordable, high-quality alternative care center for outpatient surgery that is not currently available in our community. Currently, the residents of the greater Plainfield community, they do drive about 30 to 45 minutes each way to have their procedures performed for outpatient surgery centers in other areas of the state. And this distance and travel requirements are sometimes a burden for the patients who will rely on others, family and friends, for transportation to and from that outpatient center. In many areas of the rural Northeast Connecticut, public transportation or medical transportation is simply not available, or it's limited in the geography that is covered. This proposal will allow individuals to stay in the community, close to home, minimize the barriers for receiving the care that they need. In the post-COVID-19 world, many members of our community are very reluctant to receive the care in a hospital setting. This is especially true for the elderly and those individuals with underlying health conditions. The proposal is important to the health and well-being of all residents of Greater Plainfield community and will allow the individuals to choose to have their surgery in a care setting of the highest quality close to home. Access to this high quality care close to home is one of the highest important issues for our residents, and I do urge your approval for this application. And again, thank you very much for allowing me the opportunity to speak in support for this proposal on behalf of the community that I serve.
Great. All right. Thank you so much, Mr. Cunningham. Okay, so I'm going to ask attorneys Fusco and Monahan if they need a little break to get their cross-examination together, or if you want to go ahead and proceed. Let's start with you, Attorney Fusco.
I'm ready to proceed.
You're ready. Okay. Attorney Monahan, you are too?
I am prepared, yes.
All right, perfect. Okay, so we're going to go ahead and start with the applicant's cross-examination of the intervener.
Okay, thank you, Attorney Mitchell. I do just have a few questions for Mr. Bodwin. I'm looking for him up on the screen. I don't know if it would help. There you go. Thank you. To start, I wanted to direct your attention to the petition for status that was filed in this matter. So it was filed on March 12th, and it's Exhibit P, I believe, in the table of the record. To locate that.
I'm sorry, could you repeat that?
Yep, I'm looking at the request to participate as an intervener, the petition for status that your attorney filed in this matter on March 12th. It's a 2 or 3 page document. Find a copy.
Give us. Pat, is it this?
That's it.
Okay,
Thank
thank
you.
you. I think I have it now.
Okay, super. So in that document on the first page, the very last line, you suggest that Jay Kimball is going to provide evidence concerning current access to care and surgical capacity in the applicant's targeted service area. Do you see that line? Goes over onto the next page.
Yes.
Okay, but when you submitted your pre-filed testimony, you didn't include any information regarding Day Kimball's surgical capacity, utilization, excess capacity, correct? There's none of that in your written testimony?
I believe the specifics were not included in that, correct?
Okay, but you have brought, in lieu of pre-filing, you've raised some specifics today that I would like to talk to you about. So if I heard you correctly, you said that you're currently only using 3 of your surgical suites and you're running at, was it 65% capacity, or did I get was it lower than that?
It was 62.
62% capacity. Okay.
And yes, three out of 4. And those are surgical suites. In addition, we have 2 endoscopy suites. And the combination of those suites, the utilization is 64%. And that was a 6-month period pre-COVID, so through February of 2020.
Okay. So you have, I mean, from what I can see on the OHS website, you have 6 ORs registered total, right? So that includes the 4 you're referring to as general ORs, and then you count your endoscopy suites as ORs too in your OHS inventory?
That's correct.
Okay. And I'm trying to figure out how you arrived at that number, right? So you're talking about this being a 6-month period post-COVID. So the only I'm sorry, pre-COVID. We wish we were 6 months post-COVID. Wishful thinking. The only data that we are able to look at is CHIME data from 2019. And when we look at CHIME data from 2019, it shows that in total you did around 8,100 surgical cases for the year. Does that sound like the right number?
I would have to look at notes. I'm not sure if that's correct.
Okay. But assuming that is the correct number, all of the cases within that 8,100 that are endoscopy, you do in those 2 separate endoscopy rooms, correct?
That's correct, yes.
So, and again, I have looked at the CHIME data and you could certainly verify, but I think if we backed out the endoscopy cases, it gets us down to about 5,300 cases that are not GI for 2019. Does that sound about right?
Again, I would need to access the actual information.
Yeah, I mean, and that would be in an outpatient, although, I mean, that's a clarification question. I think a majority of what you're doing is outpatient, correct?
Yes, that's definitely true.
Okay. So back in 2019, were you operating all 4 OR suites or just the 3? How long have you been doing 3 only?
Approximately, so for all of fiscal 19, that would have been the case.
Okay. So, sorry, I need to revise my math there. So assuming that number is...
Interrupt. I just want to make sure, I'm sorry to interrupt. I want to make sure you said that was the case. Was it you were operating the 3 or the 4? I just want to make sure that I understood.
The 3.
The 3. Okay.
The 3 ORs, right.
So if, you know, and again, you can verify my numbers, and these numbers we pulled from CHIME, and you know, you have your own data. But if you were doing 5,300 surgical cases in 2019 in 3 ORs, that's about, get my calculator up here. I mean, that's over, I think that's 1,767 cases per year per OR.
Yeah. Yeah, that would be the math. But again, I can't confirm right now the numbers that you're referring to.
Well, Mike, and I'll let you know where I'm going, and I can put this to Attorney Mitchell to you to see if you need clarification. But you know, if you look at the state health plan guidelines, which you've cited in your pre-filed testimony, they talk about both maximum and optimal utilization of an outpatient operating room, and assuming we're talking primarily outpatient OR. And I believe the maximum capacity number is somewhere in the 1,300, 1,330 range, and optimal being just over 1,000, like 1,070. So, if my numbers are correct based on CHIME, and you're doing, almost 1,800 cases per OR, I don't understand how you could claim you're only operating at 65% capacity.
I'm going to,
Unmute yourself.
I think, Michaela, Pat has a question. Pat, are you raising your hand? I think Pat has a question. Attorney Monahan, sorry.
I do. I object to this question and really to the line of questioning, because the witness has indicated that while Attorney Fusco is going down a road of spouting out numbers, he has indicated that he cannot verify the numbers or the information without looking at additional information. So I do not think it's fair or appropriate to have an implication of an affirmative answer or any answer when the witness has stated that he's not in a position. Now, if there needs to be a late file with information, we can do that. But this is just a calculation, a one-sided calculation going down a road where the witness has declared that he does not have the information at his fingertips.
I understood, and I'm certainly not looking for an affirmative answer, but your client is the one who raised this capacity issue in his remarks. It's not something that was pre-filed, although the testimony was supposed to be pre-filed. He's provided no evidence to support a claim that you're operating at 65% capacity. The numbers we have show different. Frankly, I'm surprised that, in a CON where you're objecting to the construction of an ASC because there's an overlapping service area and you think we're going to, take some of your surgical cases, that you wouldn't actually have your surgical data at the ready. So I assumed he would, and I understand that he doesn't. And if we need to do it by way of a late file that we're allowed to reply to, I'm certainly fine with that.
So I'm gonna, in terms of the objection, I'm not gonna allow the objection, but let me ask, Mr. Bodwin, how did you come up with the 62 and 64% capacity that you included in your pre-file testimony? If you're able to kind of explain how you got those numbers, that would be helpful.
All right, so I would have to, so these were numbers that were provided to me by our surgical services director, as well as our chief nursing officer, who are not currently present.
Okay.
So I would need to confer with them in terms of the exact calculation relative to the percentages.
Okay. So
just, I'm sorry to interrupt, Attorney Mitchell, but just to clarify, I mean, so the source of ours was CHIME data. That's where those numbers came from.
All right, so since he's unable to respond with specificity to the line of questioning on the capacity and the numbers, are there any other questions that you want to ask him?
I do. I have just a couple more cross questions. So also in that petition for status that we looked at before, you state that there's an absence of demonstrable need for an outpatient surgical facility in the proposed location. And I believe you also said that in your remarks, that there are no scheduling delays, that you're operating below capacity. So, so can we assume that Day Kimball Hospital has no plans to open its own freestanding non-hospital-based ASC, whether on its own or with a JV partner?
There are no plans at this time for that, no.
Okay. And, having seen the announcement come from your website about your relationship with Pinnacle Healthcare, it indicates that you are still looking for a strategic partner. So is it safe to assume that if you found a strategic partner and they wanted to go down the route of doing an ASC in the area, that you might determine there is in fact a need, or that one is necessary for all of the reasons we've advanced in this proceeding?
Yeah, that would.
Yeah.
Go ahead.
I think Attorney Monahan has an objection, but he's muted.
I'm raising my hand because I do have an objection. The witness has answered the question that there are no plans. The question now calls for speculation. Given that there has been discussion in testimony about various projects across the state, absent any concrete plans, I think it is unfair to ask this witness to speculate about what might or might not happen if there is nothing happening now.
All right, any response on that, Attorney Fusco?
No, and I mean, I think he's answered my question for me, which is, you know, if their position is that there's no need for this facility, that they themselves do not intend to file a certificate of need.
Well, I'm going to object. I've got to object when the response to you, Attorney Mitchell, is that now the attorney is trying to supply what she believes is the answer that the witness gave. I objected to the question before an answer was given. And there should be no speculative answer now given by the attorney.
With all due respect, you objected to my second question, Attorney Monahan, which had to do with the Pinnacle Healthcare relationship and the strategic partner. The first question I asked, which Mr. Bodwin answered, was whether there are any plans to develop an ASC, either Day Kimball on its own or as a joint venture, and he answered that no, and I think that answer was clear.
All right, so with regard to the first question, that was answered. That was with regard to whether or not they wanted to establish an ASC on their own. And then the second, with regard to Pinnacle, I'm going to go ahead and sustain that objection because it is speculative if he doesn't know. So we'll move on.
Can we just have 1 minute on mute to confer I may be done? I just wanted to check here.
Absolutely, yep.
If they don't come back to me.
Attorney Monahan, I can hear you guys. I just want to let you know if you guys are conferring, it's fine to mute.
Okay, thank you. I'm sorry for that. We do have one more question. So, Mr. Bodwin, one of the things you said in your testimony was you laid out the financial impact to Day Kimball. I believe you said if you were to lose 30 to 40% of your volume, surgical volume, is that correct?
He's on mute.
Oh, I'm sorry, you're on mute.
Sorry about that. So yes, that is what I said.
Okay, and so on what are you basing a belief that this project could cause you to lose 30 to 40% of your surgical volume?
So those are, I mean, it is difficult to predict what percentage of the volume we may lose. I was using that as a point of reference. And in Exhibit B in your reply or your rebuttal to my pre-file testimony, Exhibit B does indicate a very direct overlap in terms of service area. That's in the 41% range. And as I mentioned in my oral testimony, we believe the proposed service area that was identified in the application is somewhat subjective in that it's from Plainfield, generally Brooklyn on south, and doesn't really include towns to the north of that, which I'm not sure how that was derived, because the reality is it's about the surgeons, and if the surgeons are practicing in Putnam and they have a relationship with the ASC, they're going to take Putnam patients to the ASC as well. The 30 to 40% that I referenced was not based on any specific knowledge of exactly how many cases could migrate. It was clearly an example and a concern that we have around the overlap in the primary service areas, and again attracting physicians that are currently operating at Day Kimball to practice at the ASC and take patients out of our primary service area to the ASC.
Okay, but just to clarify, and thank you, I appreciate the answer, but the chart you referred to as Exhibit B of our rebuttal. So, what this chart is it shows all of Day Kimball's outpatient surgeries across all surgical subspecialties, okay? And that is where you're seeing that 41% number, okay? And that's 3,136 cases. So for this proposal to impact Day Kimball at 40%, we would have to take every single one of those cases across every single one of your subspecialties, including patients, with comorbidities or who otherwise need to be in a hospital setting. And that number is, would you agree, significantly more than we're even projecting for the facility in total? And it wouldn't account for the patients that we know are going to shift from our own facilities. So, I ask you only because you've thrown out some pretty big numbers, and I want OHS to understand if you have a reason to believe that all 41% of those cases could conceivably be moved to the ASC.
I'm going to object, if I may, Attorney Mitchell. If I may, the Exhibit B and the rebuttal that was provided to us speaks very plainly. It is not appropriate at this point to try to introduce background detail and facts about how methodology or calculation. We are relying on the rebuttal that was provided. And then indeed, we discussed yesterday that that's what we would rely on. It is inappropriate, in my opinion, to now try to have the attorney explain methodology that is not specified in this document.
I'm not explaining, with all due respect, again, I'm not explaining methodology. I'm asking, and I'll ask it as questions. Mr. Bodwin, do you know what the chart at Exhibit B reflects? Do you know which outpatient surgical services are included in that chart?
Yes.
Okay, and what are they? Are they are they all, or are they a select group of your services?
No, again, without completely confirming the numbers, generally speaking, they would include all, including endoscopy cases. And it would be for, the chart is obviously goes beyond, the top part is just what the applicant has identified as their primary service area, which even within the town of Killingly, turned out to be just one zip code as opposed to all the zip codes that make up Killingly. Again, seems somewhat arbitrary that they would be able to identify only one zip code as being in the service area, but not others. So really the opportunity is more than just the 3,100, in terms of the available cases that could be attracted, and the fact that the application specifically calls out orthopedics, GI, pain, and urology. There really is nothing stopping the applicant to quickly move into other surgical specialties in addition to the 4 that were noted in the application.
Are you aware of how many cases you do in that service area just in the subspecialties of orthopedics, urology, GI, and pain?
Yes, I can certainly get at that information.
If I point you to the chart that is at Exhibit E in the rebuttal, would that help you?
I'm sorry, what exhibit was that?
Exhibit E.
May I?
Yes, go ahead, Attorney Monahan.
I believe Mr. Bodwin has testified that he has access to those numbers. The numbers that now the attorney is referring, Attorney Fusco is referring them to, are from her exhibit. I would like to have a late file if you want precise information from Day Kimball Hospital, not from the applicant.
Attorney
And ma-
Fusco? Oh, go ahead.
Okay.
Wait, hold on. Attorney Monahan, finish what you're saying?
No, I'm finished.
Okay, go ahead, Attorney Fusco.
That is fine, but I mean, I will again state for the record that this is Chime data. So to the extent that they would like to provide different data, I think part of that late file is going to be a response by us asking them to reconcile the ways in which it's different, or, you know, we would like an opportunity to respond to that data, because my understanding was that we would have a free right to cross-examine them on anything that was in the record, and nothing in the record was objected to either before this proceeding or at the beginning of this proceeding. So I have no issues with the late file as long as we're given the appropriate ability to respond.
All right, let me just ask, Attorney Monahan, do you have any issue with the veracity of what is in the rebuttal? What, you know, in
Yes.
that exhibit? So you have that it's not accurate?
Yes, we do.
All right, so what I'm going to do is, rather than have Mr. Bodwin testify based upon that, I mean, it's still going to be included in the record. We'll make a determination about whether or not that information is needed at the end of the hearing, and if we need to do a late file, we'll do it then.
Okay, thank you.
Thank
You're
you.
welcome. Thank you both. Any other questions, Attorney Fusco?
No, I have no more questions. Thank you. Thank you,
Okay.
Mr. Bodwin.
All right, so let me just ask Attorney Monahan, are you ready to go forward with your cross, or do you need a couple minutes? Does anybody need a break? I don't want to keep, going if you need a break. If we can keep going if you want.
I respectfully request, can we take a 2 to 3 minute break?
Same. Thank you.
Attorney Fusco, were you going to say something?
Yeah, I was going to ask for the same. Thank you, Pat.
All right, so how about we do this, and instead of 2 minutes, how about we take about 10 minutes?
Thank
and we'll
you.
come back, it's 11:15, we'll come back at 11:25. You guys can turn off your cameras and mute. Just remember, we're still recording, so anything that you say that's not muted, it's gonna be recorded, so just be very careful. All right, we're off the record. All right, we're going to resume the hearing in about a minute. Just wanted to give everybody a heads up. All right, so it is 11:25 now. I see Attorney Monahan looks ready. Attorney Fusco, are y'all ready on your end? Is everybody set at the Hartford Healthcare boardroom?
Barbara, we're reconvening, just, we need one more 10 seconds.
Got it. Okay, all right. Okay, all right, Attorney Monahan.
Yes, I'm ready. Thank you.
Okay, perfect. Attorney Monahan, if you're ready, you can unmute yourself and begin with your cross.
Thank you.
You're welcome.
If I may, I'd like to cross-examine Mr. David Whitehead.
Just want to make sure Mr. Whitehead is available.
Yep, he's here.
Okay, all right.
Hello, Mr. Whitehead.
Attorney Monahan?
I'm just going to ask you a few questions about your testimony and your remarks. You are aware, aren't you, that there is an ASC in Norwich, which is Riverview ASC, is that correct?
That is correct.
And you are aware that if persons in Plainfield this day or before wanted to utilize that facility, they are free to utilize that facility for ASC procedures, correct?
That is correct.
So that's an option for them, correct?
Correct.
So it is really not an accurate statement to say that if approved, the Plainfield ASC will be the only freestanding non-hospital based outpatient surgery option for patients residing in and around Plainfield. Isn't that correct?
It is true because it would be the only freestanding non-hospital based ambulatory surgery center in Windham County, serving northeastern Connecticut and its communities.
No, my question is whether there is an option for a person in Plainfield with a Plainfield ASC or a Riverview ASC to go to either.
Correct, but the service area that we've identified goes beyond Plainfield, Connecticut. And yes, consumers of healthcare have options.
Correct.
And Ms. Goyette actually pointed out that we have data that supports, because we are a joint venture partner in the Waterford Ambulatory Surgery Center, that people are being disadvantaged to have to travel more than 30 miles to afford themselves, as you would state it, the option to use an ambulatory surgery center. It is our belief that Northeastern Connecticut deserves and should be afforded the opportunity to have an ambulatory surgery center, which is non-hospital based, to reduce the out-of-pocket expenses for those individuals who would choose to use that facility based on their preference and their physician's preference.
Can you point me, Mr. Whitehead, to a national standard or benchmark that prescribes the permissible limit of driving distance to an ASC from a location that is appropriate for a person to travel to an ASC to be a timely distance?
I would turn to my colleague and partner, Mr. Bitterly, on that as an operator of a number of our joint venture ambulatory surgery centers. To my knowledge, there is no benchmark that I am aware of.
Okay, thank you. And similarly, is there any state benchmark that you are aware of that has been published that sets a specific mileage to demonstrate what is a timely or an untimely distance from a patient's location or residence to an ASC of their choice?
Not that I am aware of.
Okay.
Again, I would turn to my colleague, Mr. Bitterly, for any additional insights on that question.
And Pat, and I know you can't see me, I'm off camera. This is Attorney Fusco, but Mr. Bitterly is here. He's just not sitting at the table in front of a microphone because we need to be spaced not to have masks on. So he can certainly answer these questions for you as well if you want us to get him to the table.
That's not necessary. Thank you.
Just let us know.
Now, Mr. Whitehead, you did reference in your testimony and in answers to my question, one of the what you believe and what you have put forth as the benefits of the potential ASC as the cost savings to patients, correct?
Or their out-of-pocket expenses, correct?
Well, the population that you've focused on, at least in the written testimony and in the rebuttal testimony, is on the Medicare population and the distinction between the Medicare reimbursement or payment, I should say, for an ambulatory surgery center and a hospital outpatient surgical location, correct?
Let me just clarify, in an outpatient non-hospital based surgery center, is that your question?
Well, maybe I should get to your numbers. You, in the rebuttal testimony, you talked about a cost savings of about 35% of Medicare dollars when one looks at the Medicare differential between what would be taking place at Day Kimball Healthcare, for lack of, let's focus on the intervener at issue, and your ASC based on current Medicare rates.
Attorney Monahan, can you point us to exactly what you're looking at, the page of the testimony, so we can all look at it?
Just one moment, please.
Thank you.
I apologize. I need a moment, Ms. Mitchell.
That's no problem.
Okay, I am able to refer Mr. Whitehead to the rebuttal testimony dated August 7th, 2020, and in particular to pages 9 and 10. And the question or the statement in the rebuttal that the intervener does not dispute that the ASCs represent a cost savings over HOPDs, and goes on from there to talk about difference in reimbursement, which will amount for 35% of procedures of the Plainfield ASC. Do you see that, Mr. Whitehead?
I do, and Attorney Monahan, I think you may be misinterpreting the statement. It is 35% is the procedures, not the variation and the out-of-pocket expense for a Medicare patient. 35% represents the total procedures for Medicare beneficiaries that would take place at the surgery center. If you refer to page 13 in the CON application under Table A, you will see the variation.
50%.
What about the other 65%?
Finish it. I would finish what you were saying. Can you finish what he was
So
saying?
go to
please?
if we refer to Table A on page 13, it will give you the data that you are looking for, which is the variation in CMS payment and patient payment in 2019 for ASCs and in 2019 for hospital outpatient departments.
Okay. My point being, though, is it fair to say that you are professing that there will be a differential in the savings for a patient who is a Medicare patient, whether that goes to an ASC as opposed to an HOPD?
Yeah, and I would turn to my colleague and partner, Mr. Bitterly, from an operational perspective within these ASCs. Yes, I am putting that forth, that there will be a differential in the out-of-pocket expenses for Medicare beneficiaries if they were to have those procedures done in an ambulatory surgery center.
Okay. And what about commercial payers? Do you have withdrawn? Isn't it the case that on the side of commercial payers, Hartford Healthcare, as an owner or a prospective owner of this contemplated ASC, given the multiple, and you gave numbers of over 400 involvements in other ventures and so on, perhaps 9 ASCs or thereabouts, but you have significant negotiation power to drive commercial payer reimbursement up to the benefit of the provider. Isn't that true?
I think you're making a generalization and maybe giving us more credit than we deserve in our negotiating power.
Well, do you read statements that are published in the New York Times, made by Hartford healthcare executives?
I do.
Isn't it the case?
If I may, Attorney Monahan, I'm gonna object to this line of questioning. I mean, similar to the objections that were made to me. I mean, Mr. Whitehead is saying that, he's, this is not information that we're going to disclose, first of all, in a public proceeding. And he's given a response to the question. And if going down this road means he's going to try to get us to disclose proprietary information about commercial insurance bargaining and negotiations, that's not something that we're going to be doing. I'll continue to object.
Well, Ms. Mitchell, to make it clear, I am not seeking any proprietary information. I am seeking an outright admission by Hartford healthcare executives made to the New York Times on November 14th, 2018, in which there was a statement made by the chief executive saying we're actively trying to move care toward places that are accessible. And it goes on to state that Hartford executives talk about reducing the total cost of care in the same breath that they discuss the need to charge insurers more. Quote, "The math for us is how we move the care out of the hospitals while maintaining our financial stability," Mr. Joseph said.
Okay, and if I may object to the fact that Attorney Monahan is reading from a document that he has not pre-filed, that I have not seen a copy of, that Mr. Whitehead has not seen a copy of.
We'll gladly submit it in a lay file, but I'm giving you it's
with all due
November
respect,
14th.
I'm going to interrupt. I'm going to ask everybody to stop speaking. I'm going to go ahead and sustain the objection because that is information that's not in the record, and it wasn't a statement that was made by Mr. Whitehead. So I'm just going to ask if Attorney Monahan, if you wouldn't mind moving on.
Okay, thank you.
Good job.
Well, when you, were you involved in, Mr. Whitehead, were you involved in the development of the rebuttal to the testimony of Mr. Bodwin?
I was not involved in the development of it. I did review it.
Okay.
There are other members of our team who directly developed that. There are other members of our team who directly were involved in the development of that rebuttal and can respond to any questions you may have.
Okay, thank you. May I have one moment, please?
Absolutely, Attorney Monahan.
I have no further questions of Mr. Whitehead. Thank you very much, Mr. Whitehead.
Monahan.
All right. And did you have questions for their other witness? That would be Ms. And I'm so sorry, I just had the name in front of me and I apologize.
Go ahead.
Yeah.
Yes, I do have just a few questions.
All right.
Hello, Ms. Goyette.
Hello, Attorney Monahan.
Ms. Goyette, similar to the question I started with Mr. Whitehead, have you personally had the opportunity to drive from Plainfield to Norwich?
I have.
Is it fair to say that the approximate time period is 20 to 30 minutes, give or take?
I don't recall in that drive calculating the time, but that would sound right.
Okay. Now, Ms. Goyette, much of the data that you provided, at least as I've read it in various places regarding the aging population in the application and in the rebuttal, relies on information from a document or an entity called the advisory board. Is that correct?
Correct.
And what is the advisory board?
The advisory board is a nationally recognized think tank for healthcare leaders. They do a lot of research, education.
Okay. And is Hartford Healthcare a member of the advisory board?
Of their research arm, yes, we are.
Okay. So you have access to data from them that the general public does not necessarily have access to, correct?
They have both public and private information, but in general, that is a fair statement.
Okay. Is every bit of information that you relied on in terms of the methodology that you arrived at for your conclusions, has it been presented to the Office of Health Strategy and to the intervener in this case?
Well, as I provided in my testimony, we actually look at a number of factors. We look at the US Census, we looked at the advisory board, we looked at the information you provided and that other state agencies and public have access to in terms of town profiles. We actually took the most conservative approach on that. We'd be happy to provide anything in a late file.
I understand that you took a conservative approach. What I'm asking is, there's an indication of there was certain proprietary information that you relied on, and the advisory board that was linked into your rebuttal led one to a demographic profiler that, as I understand it, and having tried multiple times, is not accessible to non-members. So my question is this: have you provided all of the underlying information in that demographic profiler to the Office of Health Strategy and to this intervener?
As it relates to the projected service area population that we've identified, yes, we have.
So there is no information, it's your testimony that there is no proprietary information that you have withheld in this proceeding.
Relative to population growth, no, there is not.
Is there any information proprietary that you have withheld with respect to any subject that you commented on in this application?
I'm going to refer to my attorney. That seems rather broad.
Sorry, I'm going to object to that. That's an incredibly broad question. I mean, health systems
Okay, I'll
use proprietary information all the time in their planning. We're talking about the application itself in a particular chart. And Ms. Goyette has testified that that information that they received, that they've provided it to OHS.
He's going to rephrase and make the question more specific.
Certainly.
Back up to the advisory board data.
Yeah, it's the US Census.
Go to the first. May I have one moment and put myself on mute so I can go look
Yes.
at a document next to me?
Yes.
Thank you for your patience. I'm referring back to question 27 in the initial application. And question 27 in that initial application provides that if population estimates or other demographic data are submitted, provide only publicly available and verifiable information. For example, U.S. Census Bureau, Department of Public Health, and Connecticut State Data Center, and document the source. Do you see that question?
I do.
The response refers back to earlier answers, which in turn refer the reader to the advisory board demographic profiler, which on the face of the page says full access to this content is reserved for planning 20/20 members. Log in to determine how membership works. Is that a correct statement?
Sure, yes. Again, we don't have that in front of us, so we can't answer that. We can fire up the website if you need us to.
Well, what I'm asking is, I've been referred, this intervener has been referred, and I believe that the Office of Health Strategy has been referred to an advisory board demographic profiler that is dated August 11th, 2020, and it's located at www.advisory.com solutions planning, which is a members only site. And that site, which is not available to this intervener, certainly, and I don't believe it is available to the general public or the Office of Health Strategy, has information that you relied on in this application. Am I correct?
What is the question, if I may interject, Attorney Mitchell, and I'm sorry, but
I'm asking the simple question.
What is the question? Because you're asking it in a very
question
convoluted
is,
way. What is the
I
question?
don't want you two to argue. I just want to make sure that we have all of the information that we need. So let me just ask Attorney Monahan. Attorney Fusco is asking, what is the question of the witness? It sounds to me like you're asking them if they relied upon data that's inaccessible to the public.
That is, the simple question is, are they relying on data in a demographic profiler that is not available to the general public?
Okay.
But the advisory board relies on data in the background that is available to the public. If you would like us to resubmit and recalculate based on the information that you provided under the town profiles, you'll note that it actually churns the what we projected to be decreasing in the market to an actual 2.7% increase. We could provide that in late file.
Well, okay, if I understood you correctly, because I didn't hear all of what you said. I understand what you just said is that you relied on the advisory board, which puts together information that you believe to be reliable.
Correct.
But you did not produce all of their methodologies and all of their calculations. You relied on it to produce what you
For
wrote.
population projections, correct, as would any applicant.
Okay, but Mike, so for me to verify the methodology, or for the Office of Health Strategy to verify the methodology used by the advisory board that you relied on, I would need to see, wouldn't I, the methodology that they used.
If I may interject, and Ms. Goyette offered, if the issue here, and we addressed this in our written rebuttal, is that, Attorney Monahan has provided public statistics and tried to compare them to ours. Now, set aside the fact that the date ranges are different. What we're offering is if you'd like us to use the public data and run them for the years we ran them, or run them the same years you did, we can do that. I mean, we explained in our rebuttal that the advisory board is a tool. It is based in large part on public data, and it is something that has been presented to, accepted, and cited by the Office of Healthcare Access and the Office of Health Strategy in many, many, many CONs over the years. And that's why we felt it was appropriate to use it. Hartford Healthcare has used it, as have many. If you would, we are offering, if Attorney Mitchell, if you need us to recast our information with publicly available data, we can do that.
So if that is an issue that's being raised by the intervener in terms of being able to verify that data, and if this is going to be information that's going to be useful for us to make a determination, I would say yes for that.
And there was some echoing here. I believe I heard what you just said, Attorney Mitchell, but if it wasn't clear, I am asking for that submission of that underlying verifiable data.
Right. And
Okay.
that's what I requested.
Thank you very much.
Okay. Any other questions, Attorney Monahan?
I may have one moment.
Okay.
I'm sorry, my screen slid down a little bit, so I am going to place it back up here. Ms. Goyette, if I don't see you, but I don't know if maybe you can hear me.
I'm right here, Attorney Monahan.
Okay, thank you. Okay, can you hear me?
Absolutely.
Okay, all right, thank you. In putting together this application, did you at all go to the Riverview ASC that was mentioned earlier and determine what type of excess capacity, if any, they had for their ASC?
It's a private surgery center. I've never been inside the building or have had access to their data.
Does that mean the answer is no, you didn't get that data?
I think you actually asked if I'd ever been inside it. So I know I've never been inside it.
So you don't, but you don't have data about what their excess or what their capacity is, do you?
I have never reviewed it. I'm assuming as part of their former applications, there's things publicly, although dated, that we could look at, but I have not reviewed it.
Okay. Until you heard Mr. Bodwin's testimony here today, did you have any, when you filed your application, did you have any factual information other than what you saw on Shine, but personal information from anyone here at Day Kimball about the situation with respect to excess capacity in their OR?
I've never had a conversation with any, I think what you're asking is a Day Kimball representative about the capacities in their ORs now.
Is it your position that Norwich is outside of your proposed service area?
Yes.
And on what basis is that?
We looked at the historical data from the Plainfield region and chose the most statistically relevant zip codes that fell into that care. I have the analyst who did that calculation in the room, and they'd be happy to answer any questions you have.
Thank you. There's no need to address any question to the analyst, Ms. Mitchell, at least for me. I have no further questions.
Thank you, Attorney Monahan.
All right. I do thank both attorneys Monahan and Fusco. I'm going to ask that we take a quick 5-minute break to allow OHS to kind of review our questions and see what's already been answered through the cross. And then we will come back and we'll do our questions. I'm just going to kind of do something informal here because it's something that I probably would do if we were all in person. But is there anybody who has a public comment who didn't pre-register? I'm going to ask you to unmute yourself and state your name. Anybody? All right, so I'm hearing no one. Time now is 12:01. We're going to come back at 12:06, 12:07. I'll give you a 1-minute reminder, and just make sure that you mute yourself and you can turn your camera off during this period because we're still going to go ahead and record. So we'll be right back. Sorry, everybody. We took a couple of extra minutes just to make sure that everybody has time to get back to where they were seated. I'm just going to give you an additional minute to just get everything set. All right, is everyone back in their seat and ready? All right.
Yes.
Thank you. Thank you. All right, so OHS is going to begin with our line of questions. We tried not to be duplicative in terms of what has already been asked, but there may be a little bit of a few questions that we may ask that, you know, may have been covered by council, but we just want to make sure that we have everything in the record and that everything's clear so that we can make a decision that's you know, based upon all of the information that we need and make sure the record's complete. If somebody is going to testify who has not previously testified, just make sure that when you do that, you state your full name and then you also spell it for the court reporter. So the first question, question number one, it's a four-part question. It's for the applicant. And I will be happy to go back and repeat portions of the question if the applicant needs. But so first, I know this is already in the record. I'm just going to ask that you enumerate or list the types of surgical procedures that you plan to perform at the proposed ASC. Second, I'm going to ask that you indicate whether there is existing access to those surgical procedures that you plan to offer within the service area. And if there is, I want you to explain why this proposal is necessary. And then finally, if you can, the fourth part of the question is, I'm going to ask you to differentiate the surgical services that you plan to offer at the ASC versus what the intervener currently offers. So I'll turn it over to the applicant for that.
Okay, and Michaela, can we just figure out the right people to answer each question? Can we just have a minute?
Yep.
Okay, so I'm going to move around, so I'm going to mute this. We're going to scan the camera a little. Bill is going to answer the question about the procedures. The procedures and
Can't hear you. Okay, there you go.
But now can you?
Yes.
Now we can, yeah.
Okay, now you can hear? 1 second. Okay, so sorry about that. We try to make sure we had all of them covered. So we can start with Bill. Ginger, if you could move the camera. Can you hear us, Michaela?
We can.
Okay, thank you.
My name is Bill Bitterly. I'm Senior Vice President of Business Development with Constitution Surgery Alliance. Last name is Bitterli. As far as the types of surgical procedures we expect to provide, I'd refer you to 171 of the second completeness filing, Exhibit A. I'm almost sure you don't want me to read you the list, but it is, this is from our scope of care at surgery centers that provide orthopedics, pain, urology, and GI procedures. So we essentially used what is existing at other centers for this filing.
Okay.
I got you. Go ahead. And then Karen, Karen can answer. So the second question, correct, was existing access to these services within the Plainfield service area, correct?
Right.
So, Karen Goyette, I'm responding. So in response to any other providers in the identified service area, it is only Wyndham Hospital on a hospital outpatient basis that is in that service area. I think the question is around access. During the last 2 weeks, and we certainly can get you additional data, we've been at approximately 86 to 110% capacity.
Okay.
And I believe the last question is regarding kind of what differentiates the Plainfield Surgery Center that we're proposing from the one existing center, which would be Wyndham. And I would really probably just bring us back to the one option of affordability, to the patient experience of being a smaller setting, which inherently has less delays and a more controllable setting.
Thank you for that. So I asked so many questions that I'm sorry. The question actually was differentiate the surgical services that you all are proposing versus what the intervener currently offers, because they are alleging that the future of their hospital is in jeopardy as a result of this proposal. So we're looking at whether or not the services that you're proposing are going to be duplicative. So I want you to talk about that and why this proposal is necessary.
Would you be able to speak to just generally what they would provide in
I apologize, Hearing Officer Mitchell. I was just conferring my colleagues just to see if there was any different answer in the room. I guess I'm not familiar enough with Day Kimball to know what their exact capabilities are and how it would be different. I could make assumptions regarding the types of more complex cases.
Only what you know. No assumptions. No, that's okay. If you could possibly speak to the difference between, I guess, outpatient services provided by a hospital versus an ASC, that would be cool.
Bill, you go ahead, Bill.
A key difference is going to be in patient selection. Ambulatory surgery centers generally only take healthier patients in what's called ASA categories 1, 2, and 3. Hospital outpatient departments still remain the service site of choice for patients 4 and 5, which have substantial comorbidities. So you'd have healthier patients, maybe patients who are a healthier patient naturally might be more afraid or have more options to go to an ASC versus acute care setting, especially in a COVID environment, whereas a patient with severe comorbidities doesn't really have that option to begin with.
Okay. This is actually out of what me and my colleagues discussed, but since you mentioned it, I think someone in their pre-file testimony, I want to say it was Mr. Whitehead, but you talked about the advantages of having an ambulatory surgical center available to people during this period that we're going through with COVID. Can you talk about some of the planned safety measures that will be implemented and how those will be different versus someone who might get that same service, whether or not it be outpatient in a hospital setting or in an acute care setting?
We're just going to have Donna Sassy answer that. She just needs to get a chair and get up to the table. There you go. Sorry, we have some disinfecting protocols that need to be followed when we switch seats.
Not a problem.
Thank you.
Thank you.
Good afternoon. My name is Donna Sassy, D-O-N-N-A-S-A-S-S-I. I'm the Vice President for Ambulatory Services in the Connecticut Orthopedic Institute at Hartford Healthcare. And I also sit on the boards for our ambulatory centers. During the COVID crisis, we had the opportunity to support our ambulatory surgery centers from a resource perspective, that being needs for masks or physical barriers, as well as we help them design their physical space to accommodate continuing to do surgery in a safe manner, social distancing, access to hand sanitizers. And so they had, so we worked closely with them for that, as well as we were able to provide them access for their patients for pre-op COVID testing. And once again, we automated that for them. They would do an auto entry, and then the, the test results would come back electronically. So we also are working to increase the communication as we move forward with any kind of crisis, whether it be COVID or any unknown. That was an example, but we have the resources and the technology to support them, and we offer that to them, and we work together and partner to protect our patients, our staff.
Thank you. And then the last part of that question was based around, it's just kind of a part of the larger need criteria that we have to look at. And so, I just want someone to explain why this proposal is necessary, given what's already in the area. And then the fact that it's common knowledge that the population in that area is rather low compared to, like, say, for example, central Connecticut. If someone could speak to that, that would be helpful.
We've based the need based on, regardless of the population density in that market, on the need to provide an affordable alternative, within that region that has no options.
Okay.
And the numbers are there. They're just
All right, thank you. We're going to go ahead and move on to the second question. I think throughout the application, there was an indication that there was going to be, I think, about 75% debt financing required to initiate the proposal, and we wanted to follow up to see if you had secured that debt financing, and if you had, from whom.
Is Jerry, is Jerry Boisvert still on the, I see you. Is that a question for you, Jerry?
I can do it.
Or Bill? You want to do it, Bill? Sure. Bill literally can do it.
The answer is that we have not secured that level of financing from any bank, both with respect to the recruitment of potential owners in terms of the equity piece, as well as the bank. Nobody is really interested in talking to us in any detail until we have a CON. So it's a little bit of a chicken and the egg. We do have pretty extensive experience with the banks in Connecticut in terms of financing projects like this. So it was touch and go there for a couple of months in COVID, when elective surgeries were canceled and the ASCs were shut down. The banks were obviously nervous about that, but we've had numerous conversations on projects since then, and we believe we're confident we'll be able to come up with that debt financing.
Thank you. All right, the next question is, statements provided on pages 12 and 23 of the main application assert that ambulatory surgical centers offer a lower cost of care. We see this in every application that we get for ASCs or OSCs. And then, most applicants will tell us that the utilization of those outpatient or ambulatory surgical centers results in a cost savings directly to patients. And one of the things that we've started asking for more now is an explanation of, not an explanation, because I think that we look more for evidence, but we ask people to cite evidence and provide examples to support a finding that that's actually true. And so we're asking you if there's any evidence that you could provide that would indicate that this specific proposal, in fact, is going to offer patients a lower cost of care versus what they would receive in a hospital.
I mean, we can put something together on that in a late file. I will tell you that there is there are articles attached, I believe, to the main CON application that talk about it in terms of cost savings, those being evidence. But if there's other information, we can kind of huddle up and see. Bill, I don't know if you.
Yeah, sure. On page 9 of the original CON file, we have a table. It's specific to orthopedics, but it applies kind of across the board. That shows what Medicare would pay and in an ASC environment for both Medicare directly to the center and what the patient copay would be. That's for 2019. It may sound like we harp on that, but that's the only consistent, one of the only consistent fee schedules is you can see exactly what Medicare will pay an HOPD in a certain geography versus what it'll pay an ASC in the same geography. We can do the same for worker compensation, and there's in Connecticut, there is about an 8% delta there, but it's virtually impossible to make a hard comparison for commercial contracts because they're all over the board. Suffice it to say that commercial payers are not interested in paying ASCs more than they pay HOPDs, and that those negotiations are ongoing. So I would put the savings delta somewhere between the worker compensation and Medicare.
So if this proposal were to be approved, then I think I read that there would be a transfer agreement between the ASC and Bacchus Hospital. Is that right? You're nodding your head.
Yes.
So I guess the question would be, and I think in my review of the record that you guys gave us kind of the average commercial cost for the provision of surgical services at the ASC. Is there any way to get a comparison between that average commercial cost and what it would cost for those same kind of procedures if they were done at, for example, Bacchus?
I just want to make sure I understand the need for the information. So if we're talking about the transfer agreement, that would be someone leaving for emergency reasons, correct?
Right. Yes.
They wouldn't necessarily be going to Bacchus to have the procedure that they were having at the ASC, correct, Bill? Yeah. Correct. So are you looking for?
We're just looking in terms of cost, in terms of the assertion that having a procedure at the ASC is less costly than at a hospital, and we can't really ask you about, another hospital in the area because you may not have access to that. We're just kind of looking for a similar comparison in terms of the average commercial cost.
Yeah, I mean, we can look at that. Mm-hmm.
I think that's all of my questions. I think that Brian is going to go next. Let me just take a quick look.
Jess is up.
Oh, Jess is going. Okay.
Good afternoon. What is the approximate distance between the proposed service location for the ASC and Bacchus Hospital?
I believe it's 13.5 miles, but
not entirely sure. We can look it up.
Okay. And can you list for the record the towns that are included in Bacchus Hospital's primary service area?
Off the top of my head. Can Donna answer? Donna Hanley.
Donna Hanley, who's with us. Donna, do you happen to have the Bacchus PSA towns somewhere accessible?
We're going to pull it up, Jen. Jen, can you hear me?
Yes.
Laura and I are pulling it up right now.
What's the address of the center? Okay.
I can just repeat it. Okay. This is Donna Hanley, DONNAHANDLEY, and the town servicing the Bacchus primary service area are Killingly, Brooklyn, Canterbury, Plainfield, Sterling, Voluntown, Griswold, Lisbon, Sprague, Franklin, Lebanon, Basra, Colchester, Salem, Norwich, Montville, Ledyard, Preston, Waterford, and Groton.
And may I ask just to clarify, Donna, is that the primary service area or is that the?
That is the primary service area, Jen.
Thank you. What is the approximate distance between the proposed service location and Day Kimball Hospital?
We're looking these things up. I mean, I can give you the information. This is Jen, or Karen can testify. We've looked up Bacchus.
It's approximately 19 miles. I'm sorry, 18 miles and 19 minutes.
Is that drive? That's driving.
That's driving for Bacchus.
You're looking that up on like Google or MapQuest?
Yeah, Google Maps. Yeah, Google Maps. And then
All right,
Day Kimball.
I guess I'm going to take official notice of Google Maps.
Sorry.
And Day Kimball is.
All right.
Probably available then.
The mileage in minutes between Day Kimball and the proposed location is 18.9 miles and 22 minutes. And again, same source, Google Maps.
Great, thank you. And can you indicate for the record the towns that are included in Day Kimball's hospital service area?
If you know.
We wouldn't have that information. We don't have that information available.
Okay.
It's just
Thank you.
Can we ask the intervener to provide that information?
Yeah, we'll do that. I think we'll do that at the end. Yeah. Are those all your questions, Jess?
Yes, thank you.
Okay.
Okay, this is Brian Carney again. I have I have several questions for the applicant related to service area. And specifically, I'd like to know how was the service area defined for the proposed ASC?
You want to do it? Sure. Can we? Barbara Dirty's going to answer that question. We just got to try to pan the camera around. Can you see her? There you go.
My name is Barbara Dirty. I'm Director of Strategic Planning for Hartford Healthcare, BARA, DURDY. So we defined the service area by taking a 20-mile drive radius, 20-mile radius around the proposed site.
I think it was, yeah, I mean, I think it was like it was more approximate than that. We were also looking at
and that's why
we
only
put
the
it in
one
here.
zip code from Cunningly is included because it fell within the 20-mile radius.
Yeah, it's here, Barbara. This is exactly how we described it. So you have the.
Yeah, I have it. Yep. Yeah. Mhm.
So for the most part.
For the most part, 20 miles, yes.
Barbara, I missed the last part that you said about Killingly. Can you repeat that? I just want to make sure I heard it.
So that's why only one zip code was included, right? Because it's only that one zip that fell within the approximately 20-mile radius.
Okay. Okay, I'm sorry, Brian.
So the intervener asserts that the service area for the proposed ASC overlaps with its service area, provides a detailed explanation regarding why your proposal will not result in any unnecessarily duplication of services. And also maybe you could include sort of a discussion of Exhibit B of your rebuttal, which is sort of topic related.
On this exhibit B, yes. Do you want me to speak to this, Jen?
Sure.
Okay. So can I refer you to Exhibit A? It might be helpful to look at the map as we talk about the service area and the overlap. So as you can see on the map, there are only two towns, Brooklyn and Plainfield, that overlap, and one zip code from Killingley.
The page for that, Exhibit A page?
Exhibit A in the rebuttal.
In the rebuttal.
On the rebuttal, okay.
Yes.
Give me 1 second. Okay, I'm just gonna rotate it and I have it up.
For the towns that are light purple or lavender, those are the areas, towns that overlap. And that area also includes the southernmost portion of Killingley, which is that one zip code. That's the overlap.
Okay.
Exhibit was this Gen B. Okay. So Exhibit B, which is the detail of the Day Kimball Hospital outpatient surgery cases, HOPD cases, that lists all of their surgical cases, all specialties by patient town of origin. The top part of that chart that foots down to 41.4%, those cases originated from the service area that we've defined for the Plainfield ASC.
Okay, so it looks like there's 3 instances of overlap in that top part, Plainfield, Brooklyn, and Killingley.
Correct.
But as you said, that's for all procedures and not just for the procedures proposed at the ASC.
That's correct. So what's represented there are cases from all surgical specialties, not just, not only from the 4 that we've identified for this proposal, but that represents all surgical cases.
And that doesn't factor in your anticipated capture rate either, does it?
I'm not sure. Can you clarify that? What do you mean by capture rate?
Yeah, so like in the main application on page 31, you're assuming a certain capture rate.
No, it doesn't. So we've assumed a certain shift in cases based on market intelligence we have, interest from physicians, a certain percentage of each identified specialty would shift to the ASC.
So if I add those 3 percentages that are the overlap, I come up with 33.7%, but that's for all procedures, and that's not factoring in that you wouldn't capture necessarily all of those patients.
That's correct.
Fair assumption.
Okay. Go to Exhibit E for
Exhibit
just the
E, yeah.
lines.
If you, Brian,
Yeah.
go ahead.
Brian, if you want to refer to, if you could take a look at, if I could refer you to Exhibit E and our rebuttal testimony, I think it's probably more clear how our volume was determined, how the proposed volume was determined.
Okay, I have it up.
Okay, so let me just walk you through what the data on this chart depicts. So if we look at the top part of this chart, what we have here is, first of all, the source of this data is CHIME, HOPD surgical volume for these 4 specialties originating in the service area towns. And it's sorted by hospital or provider. And then across from left to right, you have the surgical specialties. So if you look under the column labeled ortho, there are 1,112 hospital-based orthopedic cases originating from this service area. And you can see which hospitals they were performed at. Out of the providers, Hartford Healthcare Hospitals performed 674, or 61% of the orthopedic volume originating in that service area. We projected in our CON that we would, year one, the orthopedic volume would be 647. So we estimated that 58% of that volume would shift, largely from our hospitals is what we're anticipating. Dade Kimball Hospital did 189 of those orthopedic cases, and that represents 17% of the volume. And then, you can just walk across, it's the same calculation for each specialty.
Okay, so the 58% is calculated how? So one more time. It's
So the 58% represents our best estimate, based on physician interest that's been expressed, market intelligence. We know the types of cases that physicians do in ASCs, and it's our best guess what percentage of those cases would shift to the proposed ASC.
So it's 647 divided by 1112, and that's
correct.
Okay.
Correct.
All right.
Is that helpful?
Yeah, that is. Just to follow up about an overall sort of answer, the applicant's asserting, or the interveners asserting that this would be a duplication of service, a duplication of services. How would you respond to that?
Yeah, I think Karen can answer that if we hand the camera over.
We're really offering an alternative care setting. If anything, I think it's a duplication of our care services in the Wyndham market, not of the interveners.
And this is Donna Hanley. If I may also add, at Wyndham Hospital, our physicians have frequently come to discuss that they are having increasing denials from payers for patients who can have surgery in an outpatient setting and denying surgery at our hospitals. So this is being driven by patients and physicians as well, to have an alternative site that is convenient and really fits into the coordinated and continuum of care for our patients.
Okay, thank you. Just kind of a follow-up too. We talked a little bit about, it was brought up about two alternative ASC providers. It was brought up in Mr. Bowden's pre-filed testimony on page 2, stating that in Eastern Connecticut, Connecticut Endoscopy Center, LLC, and River Valley ASC are other providers in the area. Is the reason that those were omitted from your application due to the fact that they're not specifically defined or part of your primary service area?
Yes, that's correct. Also, I believe, as a legal matter, I included in my rebuttal that the state health plan specifically states when you're applying for a multi-specialty ASC that you can exclude the volume of a GI only of an endoscopy center, so that particular center wouldn't be relevant regardless. And
Okay.
River Valley ASC is not within the service area.
Okay, it's kind of an apples to orange comparison.
Absolutely.
Sorry.
Yeah, that's fine.
All right, last one has to do with quality of patient care kind of question. So the question is, enumerate and elaborate upon the benefits of an alignment between Hartford Healthcare and the proposed ASC as it relates to the quality of patient care. So how is this going to improve patient care? What are the benefits of being a member of Hartford Healthcare system?
Donna Sassy can answer that. If we can get the, there we go.
So from a quality perspective, we partner with our ASCs in a way to provide resources. We also share best practices, policies, standards We open up our councils, our periac councils, to our ASCs. Our employed physicians are available, specifically ID during COVID. They were able to access and question and validate practices. From an infection prevention perspective, we share best practices. Our ID staff is available to them. We have technology that can back up if they have technology that goes down. We do share. During COVID, the ASCs provided us with a list of their equipment and services that and staff that they could loan us in order for us to continue to care for the COVID patients during the acute phases. So in every situation, we optimize our relationship to be able to provide the highest quality of care and safety to our patients and the communities that we serve.
Okay, I'm sure you probably said this, how many physicians will be owners or part owners of this new facility? Do you know a number?
We
project 13.
As I mentioned, we have not syndicated yet to owners, but we are anticipating, I think we provided that somewhere, 4 orthopedic owners, 3 urology. I would say about 10 or 12.
We had a specific number, yeah, I'm just looking for it.
Roster. We would expect, because of the nature of the placement of this ASC in a less dense market, as we've been discussing, that there would be a number of non-owner, a greater percentage of non-owner utilizers of the center. In particular, the orthopedists that we've been talking to are sort of community surgeons that have privileges at HHC hospitals, at Day Kimball, at other hospitals around the state. But a lot of the demand, as Donna Hanley mentioned, for urology, GI, and pain is coming out of HHC employed physicians. So we're really responding to the demands from surgeons and their patients for a more convenient option. And with no ASC in that area, and their only option is an HOPD site, which is not the same thing.
And so the physicians that are going to be practicing at the new ASC are likely to have privileges at one or more of the other Hartford Healthcare hospitals?
Absolutely, that's true of every ASC. Very few physicians do 100% of their work anywhere. They're following their patient population.
Because of the risk factors.
I'm sorry?
Because of the risk factors, the comorbidities.
Exactly. So every surgeon at an ASC will have privileges at least one nearby hospital. In an area like this, we would expect them to have it at multiple hospitals.
Okay. So we thought it was about a dozen? Is that what we came up with?
It's 13, Bill.
13, sorry.
Lucky 13. Okay, thank you. I don't have any further questions. Thank you very much.
Thanks, Brian. Thanks, Jessica. So at this time, I'm just gonna ask again if there's anybody that has a public comment that they unmute themselves and just state their name so that I can go ahead and let you speak. It's quiet. I just want to give it another second in case somebody's trying to figure out the technology.
I'm not seeing any hands raised or movement.
Got it. Okay. Thanks, Brian. All right. So before we go to the closing remarks, I'd like us to talk about some late files that I want to request. I will say, just for the record, that we are going to go ahead and leave it open for a week. So it's going to be open until August 19th, unless attorneys indicate to me that they need additional time for the late files. But that is for the submission of any additional comments that people want to send us. And so those comments can be addressed to CON comments with an S at ct.gov, or they can be mailed to us at the Office of Health Strategy at 450 Capitol Avenue, M like Michaela, S like strategy, number 510, H like high, S like school. P.O. Box 340308 in Hartford, Connecticut, 06134. So I'll leave the record open for that until August 19th at 4:30. And then with regard to the late files, I actually have a request for both the applicant and the intervener. I'll start with the applicant. With regard to the first late file, it kind of goes back to the questioning that was given by Attorney Monahan regarding the population demographics and the applicant's offer to use only the publicly available data. So I'm going to ask that if you could recalculate that using publicly available data for the most recent period that you can access. I know that what you had was probably, I guess, more recent than what you could get publicly available, but for the most recent period that you can access, I'm going to ask that you provide that you cite your data sources, and if there's any, if you take that data and you manipulate it, just make sure that you disclose what your methodology is to arrive at your demographic projections. And then the second thing was the average commercial cost for similar procedures that are proposed for this specific ASC. The average commercial cost for surgical procedures that are similar to what you propose at the ASC in comparison to what those are going to be at Bacchus. I can't even see straight. So just average commercial cost for what that would cost it if they were to go to Bacchus for those procedures.
Okay.
And so that's going to kind of help us with the cost. We won't need you to submit any additional articles related to costs and ASCs being less costly, because this is going to kind of help us with this specific application. So those are the two things that we want from the applicant. And then from the intervener, what we'd like to see is a list of what towns are in your primary service area. And then we also want to see for fiscal year 2019 what your surgical capacity was by OR suite designation. So we want you to break it down by designation for fiscal year 2019.
Is that, Michaela, can I ask a clarification point? Is that capacity and utilization? So
yes.
How much they can accommodate and how much they had?
Yeah,
okay.
Right. I was going to ask too if we could get that same information from Bacchus. So that's kind of in the area. All right, and I just want to ask, I'm going to go with Attorney Fusco first. How much time do you think that you might need to provide this information? If you want to confer with your clients.
I was going to say about at least a week. I mean, give us a week. If we need more than that, I'll let you know, but we could probably get it done in a week.
All right, and then also Attorney Monahan, how much time do you think you might need?
1 week is fine.
Okay, so we're going to leave the record open then. Again, I'm going to confirm it's going to be August 19th by 4:30. I think that's all that we need. I'm going to go ahead and turn it over to the applicant and the intervener for closing statements. I'm going to have the intervener go first, and then the applicant's going to get the final statement for the closing. So Attorney Monahan, do you have a closing statement? Mark?
I do, and I appreciate the opportunity to briefly give some remarks. What I really think at issue here is a fundamental remembering that we are a CON state, and that we are a CON state with 12 statutory factors, the integrity of which should not be loosened or lessened by the fact that there are systems doing wonderful things, but that systems have the ability to expand and grow into every corner of this state. My belief is when we look through this system, these statutory factors, and then we look at the community hospital that has been here for numerous years, serving this population, and you are hearing firsthand about the cracks in the foundation that this can pose to it, to serve the very population that does have a choice right now, whether it be 20 or 30 miles away or 20 or 30 minutes away for ASC services. But for all the comorbidities, for all the acute care needs, for all the Medicaid population, for all the vulnerable populations, this is one of our remaining community care hospitals that I believe a CON state, which we are, is designed to protect. So when we look through these factors, I do not think they should be loosened up, for instance, on the clear public need. Public convenience is a wonderful thing. Patient convenience is a wonderful thing. But that alone does not establish public need. Improvement of a healthcare system is important, but improvement of a healthcare system across the state is critical. And Day Kimball Hospital, while it's $1, may be relatively nothing compared to dollars of other systems, is critical for this region. And this CON statute is designed, while this legislature has us in the CON world, to protect Day Kimball Hospital in this instance. The second thing, or additional thing, is there really isn't an identified population here. There is a region that's been sort of loosely described. And there's also been a discussion of population of patients saying to, albeit Hartford healthcare related surgeons, about a desire to go elsewhere. That does not drive a CON decision in our view. And then the most important factors, and I really are the 11 and 12 factors, that when we are talking about does this adversely affect healthcare costs or accessibility to care? What we are talking about is whatever the benefits may be of these wonderful ASCs, they should not overpower and diminish the responsibility, the duty, the long-standing loyalty that a full-blown acute care hospital such as Day Kimball has served for this region, not just this town, this region for all these years. And while the evidence came in about quality of care in various respects and cost of care, there is no assurance, and no one can give any guarantee, that the commercial insurance costs are going to be guaranteed to be less than or better than any other commercial costs from the proposed Plainfield ASC than elsewhere. And with that said, I would just simply close by saying we are here because of CON. And if there was ever a situation where CON should be held with integrity for the provisions as they were designed, this is it. We are being tested as a state. Things may change in the future, but in a state where systems are spreading, but there are still community hospitals in specific regions performing wonderful services across the board, this is what our state has designed to protect. Thank you. I can't hear you.
You're muted. Michaela, can I start?
Thank you, Attorney Monahan. Attorney Fusco?
Thank you.
Thank you both.
Thank you. I mean, I want to start out by thanking Attorney Mitchell and all of the OH staff, and actually everyone who's participated in this on our side, on the Day Kimball side, those who are, participating in the meeting. Like, this has really been an unprecedented effort to get this first of its kind remote hearing up and running. And I think it went really well. And I feel like it gave everyone a fair, chance to be heard who wanted to be heard. Also very appreciative of the time it's taken for you guys to process this application. I mean, we're now more than a year in. And this process has just completely changed both for you and for us. So we appreciate your patience and your diligence in doing all of this for us. But I'm going to speak briefly as well. While I appreciate everything that Attorney Monahan said, it won't come as a surprise that I take somewhat of an opposite view on this with respect to this proposal. So if you look at the statutory decision criteria, I mean, the way that OHS looks at CON proposals has evolved considerably in the last several years. And from what I've seen, the agency's focus has moved away from kind of a formulaic needs assessment and is focused more on whether a project is needed because it improves the quality of care, the safety of care, the affordability of care, and provides access to consumers and all different patient populations, including Medicaid and uninsured. So, we're seeing an evolution in decisions where there's less of a focus on need and more of a focus on these other decision criteria that are equally, if not more important in many cases. And as you'll remember, years ago, there were discussions in this state about whether our certificate of need statutes should even have need criteria at all. So, that being said, I think that OHS needs to take a careful look at how this proposal not just meets the need criteria, but meets all of the statutory decision criteria, including quality, affordability, and access. Basically what this proposal represents, and I'm repeating things that were said by witnesses, is, Hartford Healthcare, with the assistance of an experienced partner in Constitution, basically proposing to disrupt its own services so they can make an investment in an ASC that's going to serve as a more affordable alternative for the systems patients. Okay, there's been a lot of discussion today about Day Kimball, what they do, what we propose to do, whether there's a duplication, whether there's going to be an adverse impact. If you look at the numbers on the chart that Barbara Dirty referenced before, you can see that there is enough HHC hospital surgical volume in the service area to more than cover the modest amount of cases that are projected for the ASC. And we do expect that many of our patients will choose to use the ASC, and that we don't need to take volume from Day Kimball Hospital in order to make this project work, to meet our volume projections and make it financially feasible. We're doing this because we want to provide that alternative care setting. We know that our patients are, they only have the choice of hospitals, and whether you argue that River Valley is in the service area or not, it is not in our defined service area. They are not sitting at the table today opposing this. Like, within our service area, there is no ASC capacity, there is no ASC option, and we want to afford that to our patients. And I think that affordability of healthcare services is a goal that, Hartford Healthcare and Constitution share with the state of Connecticut. And it's one that has become, increasingly important now with the economic instability brought on by the COVID-19 pandemic. So, if you think we were talking about patient out-of-pocket costs and expenses before and the affordability of care, I think that's only going to become, more and more important as we move forward. Getting back to the basics of access, this is, having a health system partner ensures that this facility is going to be accessible for all patients, for Medicaid patients, for the uninsured. Just like with all of the other surgery centers, we're going to adopt HHC's financial assistance policy. So all of those protections are guaranteed. You've heard from Donna Sassy and Bill about sort of the quality and safety benefits of having HHC as a system partner in this AHC, that quality, again, these things are really important to patients right now. As we reopen the healthcare delivery system in a post-COVID world, patients are scared. Many patients don't want to go into an acute care hospital for any reason, for any type of procedure. And so having this alternate care option is going to be beneficial for those patients. And so, looking more at the traditional need, we have shown that the Plainfield area population is growing, and you're going to see that in the publicly available data we submit, because it was in the publicly available data that Dave Kimball submitted. It's growing, it's aging. We know that more procedures are shifting to an ASC setting due to, patient and physician preference and, pressure from payers. So the need for an ASC, the need for that setting is going to grow. It's going to be vital. And so, given that we feel strongly that we've demonstrated that this will have little to no impact on existing providers like Dave Kimball, because of the fact that we're doing this to address the needs of our own patients. And because we're going to see this growth, we think that you can say that there is a more traditional clear public need for the facility. But what it really comes down to at the end of the day is consumerism in healthcare. It's giving patients a choice of a more affordable and accessible care setting. And meaningful choice and affordability are key considerations more now than ever in healthcare delivery. So these are the reasons we want to do this. And we feel that we have met those CON decision criteria that we've discussed and that Attorney Monahan raised. So for all of these reasons, we would ask you to approve our CON. And once again, we thank you so much for all the work today and throughout this process.
All right, so I want to thank both the applicant and the intervener, attorneys, everybody that participated. You guys helped make this very easy for us. This is our first hearing, so I thank you all. We're going to leave the record open until August 19th, but for now we're adjourned. I hope that everybody stays safe, and until next time, the next hearing, maybe I'll see some of you guys, but hang in there.
Thank you.
That.
Thank you, everyone.
Thanks.
Thank you.